Happy Wednesday. Welcome to Grand Rounds. I'm Dr. Sutherland. I'm one of the chief residents. I'll be introducing our speaker, Dr. Petri, who'll be giving our talk on Grand Rounds this morning, or this afternoon now. Dr. Petri is a professor of medicine in the Division of Rheumatology and director of the Lupus Center at the Johns Hopkins University School of Medicine and Johns Hopkins Hospital in Baltimore. She earned her medical degree at Harvard Medical School and completed her internship and residency in internal medicine at the Massachusetts General Hospital. Thereafter, Professor Petri completed her postdoctoral fellowship in allergy, immunology, and rheumatology at the University of California, San Francisco. She subsequently earned her master's in public health and epidemiology from Johns Hopkins University, Bloomberg School of Public Health. Professor Petri's research focuses on several aspects of systemic lupus erythematosus, SLE, including atherosclerosis, antiphospholipid syndrome, lupus nephritis, and pregnancy. The Hopkins lupus cohort, started by Professor Petri in 1987, is a longitudinal study on the incidence and pathogenesis of thrombotic events and coronary artery disease in SLE. She is a master of the American College of Rheumatology and was chair of the Lupus Now Education Program. Dr. Petri today will be giving a presentation on the topic of updates in SLE classification, treatment, and complications. Dr. Petri.
Thank you. This was supposed to be one of my clinic days, but since Cecilia invited me, I told her for her, I would cancel clinic. And it's interesting that you reminded people about Wednesday at Hopkins. One of our administrators is very big on making us happy. And so when I walk in the morning, she always says to me on Wednesday, "Wonderful Wednesday." Now, here are my learning objectives. And the first thing I wanted to convince you of is that lupus actually is a rare disease. We have good data on how many people in the United States have lupus from the Centers for Disease Control, and it's 200,000. Now, you may have been taught, as I was, that lupus is more common in African Americans, and that is true. But you see on this slide that the highest point prevalence is actually in Native Americans and Alaskan Islanders. Now, many of you are going to say, I don't have people with lupus in my clinics. Why am I interested in this talk? Well, I need to convince you that the autoimmune pyramid is everywhere. And so it turns out at the bottom of the pyramid, 1 out of 5 completely normal women have a positive ANA. Now, this means that you should never refer a positive ANA patient to rheumatology. At the next level are all the people who have a localized autoimmune disorder. And every specialty has a handle on one of these. GI has a lot of them, for example, inflammatory bowel disease, autoimmune hepatitis, sclerosing cholangitis. Cardiology has myocarditis, pulmonary has all the interstitial lung diseases. Most of these patients will not develop a systemic autoimmune disease. It's like there's a break on their immune system. It'll go after one organ, but not all organs. At the top levels of this pyramid are where rheumatologists get involved. We're the ones who treat the systemic autoimmune diseases. And one of the most common is actually undifferentiated connective tissue disease. And when I tell patients they have this, they say to me, but another doctor told me that was a garbage diagnosis. It's not. It means the woman usually has limited systemic autoimmunity. And in fact, she only has about a 10% chance that she's going to go on to a named diagnosis like rheumatoid arthritis, lupus, or myositis. Now, this is very common, and it turns out we learned this from lawyers. And you're going to say you never learned anything from a lawyer. Instead, you get that fear, emotional feeling when you get a letter from a lawyer. But it turns out lawyers started to study the silicone breast implant controversy. Of course, first they just wanted to sue everybody. But then there was actually a case control study. And it was very important because it showed that 5% of women who had never had a silicone breast implant had undifferentiated connective tissue disease, exactly the same prevalence as there was with a silicone breast implant. So it could not be causative. Now, at the top, I put lupus, but that's because I'm biased. I take care of people with lupus. But the most common systemic autoimmune disease is probably Sjogren's syndrome, the autoimmune dry eye, dry mouth syndrome. And of course, rheumatoid arthritis is much more common than lupus as well. Now, we have classification criteria for lupus. In fact, we have too many classification criteria. We now have 3 of them. The good news is they all work. And the point of classification criteria is to point out that lupus is usually a multi-system disease. Now, here are the clinical criteria. A person has to have at least one of these. The total has to add up to 4 to classify as lupus. And you see circled in red all the cutaneous manifestations, and I'm going to show you most of those in photographs. And next you see 4 other organ systems that can be involved. Joints are very important because about 80% of women with lupus will have joint involvement. Then serositis, which of course includes both pleurisy and pericarditis. Renal. Now, renal is very common. 70% of African Americans will have lupus nephritis and 50% of Caucasians. And then neurologic. And lupus is fascinating because it can affect almost any level of the neurologic system, from central nervous system to spinal cord to peripheral nerve. And then at the bottom, circled in light green, are the 3 hematologic lines, and lupus can affect all of those. It can cause a hemolytic anemia, leukopenia, and thrombocytopenia. So remember, the person has to have at least one of these. And then they have to have at least one in the autoantibody family. And ANA is still there. Problem with lupus is, of course, most patients will have a positive ANA, but we don't have an actual threshold. So in the newest set of criteria, they say you have to have an ANA of 1 to 80, but it turns out 6% of lupus patients will either have a titer lower than that or will be negative. Now, anti-double-stranded DNA is a very specific autoantibody for lupus, but beware the ELISA assays because they have a little gray zone, an indeterminate zone. Then the next one is SM, and it doesn't stand for smooth muscle. What organ system is smooth muscle? Liver. It stands for Smith. And it turns out that Mo Reichland, the rheumatologist who discovered most of these autoantibodies in people with lupus, named them after the patient in whose serum he found it. And I think it's a wonderful story because these patients will live on forever, but you realize it's not HIPAA compliant anymore. Now, the next one are antiphospholipid antibodies. And of course, you know about those, and you know they're not specific for lupus, but 50% of people with lupus will have them. Of all of them, it's the lupus anticoagulant, which is most closely associated with both thrombosis and adverse pregnancy losses. Now, next is low complement. And I hope you're always suspicious of lupus when you see someone with low complement. But of course, there can be other causes for low complement as well. And finally, at the bottom, you see the direct Coombs test, the antibody against red cells. Now, some of you will remember on the previous slide, there was hemolytic anemia, and you're going to say, isn't she double counting? But it turns out that a whopping 90% of people with lupus with a direct Coombs test will never manifest a hemolytic anemia. So that's why it's also counted here. So remember, you need a total of 4 from these 2 slides before you should confidently classify the person as having lupus. But now let's go through some show and tell, because a lot of lupus is based on physical exam findings. And let's start with the so-called acute cutaneous lupus. We don't call it butterfly rash anymore. And there's a good reason, because most patients aren't going to have a florid rash like this poor lady has. In fact, I've always wondered, why was she smiling when this photograph was taken? Can you imagine how devastating that must have been to look like that? But sometimes the manifestation was in the past. The patient isn't showing the rash when you're face to face with them. So what kinds of questions could you ask to get to the bottom of whether or not it actually was a lupus rash? Well, first you ask about sun exposure, don't you? But you may be surprised to learn that the lupus rash doesn't occur on the day of the sun exposure. Why? Because it takes time for immune complexes to form and then to have the inflammatory cascade, including activation of complement. So lupus rashes will usually occur on the next day or the day after that. A rash that occurs on the same day as sun exposure might be something called a polymorphous light eruption or solar urticaria. Now, your next question is, how long did the rash last? Lupus rashes will last for many days to weeks. If the rash only lasts for a day or two, then it's probably not lupus. And then your final question will be, is the rash raised? Now, looking at this photograph, it's obvious it's raised, isn't it? It is inflammatory. If the rash is absolutely flat, it's more likely a flush or a blush. Very unlikely it's lupus. Now, of course, there's some other inflammatory rashes of the face, which are raised. Acne, seborrheic, all these things are in your differential. But when the patient does have the rash right in front of you, it may not just be a cheek rash. Maybe it's a little spot here. You get a lot of sun exposure on the side of your face, for example. So sometimes even a rheumatologist is not sure, and we send the patient to a dermatologist for a biopsy. But looking at this lady, it's obvious, isn't it, that her rash is photosensitive. It spares the nasolabial folds. It spares below the nares. If you saw an inflammatory rash that involved the nasolabial folds, what disease would you think of? I hope you'll think of dermatomyositis. That's one of the ways to tell a dermato rash from a lupus rash. Now, this lady has chronic cutaneous lupus. We still use the old name, discoid lupus, for this. This is a much more severe rash because it involves the deeper layers of the dermis. So just like a third-degree burn, when it heals, it will heal with hypo and hyperpigmentation. In fact, there are only a few areas right at the base of the neck that still have scale. Those are the areas that are still active. The rest of this is irreversible. It's called non-scarring alopecia. Can you imagine if you're a teenager and you look like this? One of the first things I did when I arrived at Hopkins 37 years ago was I told the director of the outpatient center that he had to put mirrors in all the examining rooms I used. And of course, his first question was, who's going to pay for it? But his second question was, why? And I told him that many of the ladies who saw me had to have a mirror to put their wig back on after I examined them. And he got it, and all the rooms now have mirrors. Now, I mentioned that 80% of people with lupus will have inflammatory joint involvement. But what's a little confusing is it shares the same distribution as rheumatoid arthritis. So how are we going to tell it apart? Well, hopefully we can tell it apart through the serologies and the other laboratory tests. But sometimes we tell it apart based on the physical exam. So when you saw this photograph, you thought this person has deformities, it must be rheumatoid arthritis. Lupus arthritis can also cause deformities, but the big difference is they are reversible. So if you or I could reach into this slide, we could straighten the fingers because the deformities are not due to bone erosion, they're due to tendon and ligament laxity. Now let's talk a little bit about pathogenesis. Why do people get lupus in the first place? And so I would start with this cartoon, that figuring out the human genome map was easy. The hard part is refolding it. So how much did we pay for the Human Genome Project? Anybody want to get in within $1 billion of it? It was 2.7 billion. But it's the only government project in history that came in 2 years early. And it turns out we did learn something from it about lupus causation. So here's one of the Manhattan plots of a GWAS study for lupus. And you can see by far the most important are the HLA genes. But some of the other genes that were discovered to be predisposing turned out to affect pathways that weren't well recognized as causative of lupus, including the interferon pathway, but also several B cell pathways were also identified and immune complex processing. Well, if lupus is half genetics, it follows that it must be half environmental. So if you have the genetic predisposition, what are some of the environmental things that would trigger lupus? Well, it's very confusing for patients because, they want to pick a trigger that was recent. And we have to tell them that their lupus autoantibodies were present for at least 5 years before they had a clinical symptom. So it won't surprise you that probably the environmental insults are happening very early in life. Ultraviolet light is one of the most important. There are drugs, but they're not the ones you memorized as causative of drug-induced lupus. It's not things like procainamide, hydralazine, and isoniazid. It's things like trimethoprim sulfa, the antibiotic, and echinacea, which is not a placebo. It actually does activate the immune system. Smoking is a really important precipitant, and in fact, that awful photograph I showed you of discoid lupus, it turns out smokers are 6 times more likely to get discoid. In terms of infections, childhood exposure to EB virus has been proven in multiple studies to lead to later lupus. And then the bottom 3 are environmental pollutants. So knowing how our environment becomes more and more polluted, it won't surprise you to learn that there are recent studies that suggest that the incidence of lupus has doubled. Now, why do women get lupus much more so than men? Well, we thought it was a simple answer. We thought it was estrogen. And often in rheumatology, we're just proven to be wrong. And so now there is an explanation for why women get more lupus and more autoimmune diseases in general, and it's X-ist. This has to do with X inactivation. And it turns out it never goes perfectly well. And so there are parts of that second X that won't be quiet. And they can make X-ist, which is long non-coding RNA. And the reason this is important is that it can act as a TLR ligand and activate the immune system. Now, how does lupus start? Well, this was work that was done by my former boss and his wife, the Rosens. And it turns out this is now nicknamed the garbage disposal hypothesis of lupus. There's a problem in people who are destined to get lupus at the level of programmed cell death. Now, in you and in me, this is happening billions of times a day. And our macrophages know to gobble up the dying cells in a non-inflammatory way. But in someone destined to get lupus, a mistake is made. And the macrophages engulf these dying cells, but in a pro-inflammatory way. On the right, you see a photograph of an apoptotic cell. You see all those little bodies around it. This is how the proteins that lupus patients make antibodies to, like Rho, LA, RNP, Smith, are initially presented to the immune system in these small apoptotic bodies. But then there's a feed-forward loop. So you first break tolerance, and then lupus occurs because of this feed-forward loop. So if we start at the very top, plasmacytoid dendritic cells make interferon, and a whopping 50% of people with lupus have the interferon gene signature. They're making interferon all the time. It never shuts down. And this can activate the myeloid dendritic cells. Those are what you think of as monocytes and macrophages, which do 2 things. They present antigen to T cells, but they also make a protein called BAFF that allows B cells, including autoimmune B cells, to live longer. And then, of course, the B cells are making autoantibodies, which can then bind to the self-antigen, and those activate the plasmacytoid dendritic cells through those toll-like receptors. Now, we need this feed-forward to work when we get an infection, but then we shut it down. The problem in lupus is it's always going full speed ahead. Now, if you remember one thing from my talk, please remember this. In fact, when I talk with rheumatologists, I ask for audience participation, and I tell them the P in prednisone stands for, and they have to answer poison, because it is. And we still use it. It's one of the most frustrating parts of rheumatology practice. Why do we use something that causes long-term harm? Well, because it works fast, and it's cheap. But here's our problem. This was a longitudinal study that I did in my cohort. And back when this study was done, the biostatisticians had just invented a way to adjust for confounding by disease activity. Because obviously I wasn't prescribing prednisone for the fun of it. I was prescribing it because the patients needed it. And what you can see here clearly is there's a break point. When the prednisone maintenance dose gets above 6 milligrams, there's a 50% increase in later permanent organ damage. And if heaven forbid we have to get above 18 milligrams, there's a 2.5-fold increase in permanent later organ damage. Yes, most of this organ damage is going to be musculoskeletal, which means osteoporotic fractures and avascular necrosis of bone, or ocular, meaning cataracts. And you're going to say, well, these things don't kill. But osteoporotic fractures happen primarily in the lumbar spine in people with lupus. You can't put a splint or a cast on the lumbar spine. And avascular necrosis of bone is terrible because it usually is bilateral, both hips, and many patients will also have knees and shoulders involved. But prednisone damage includes things that can be fatal. And in particular, I wanted to draw your attention to cardiovascular events. In this analysis, we had to include all the traditional cardiovascular risk factors, as well as disease activity. And we found a clear dose response for the prednisone dose in the 3 months before the event. And you can see if your maintenance dose is 10 milligrams, you have over a 2.4-fold increase in an event. But if you've gotten to 20 or above, you have over a 5-fold increase. So yes, prednisone can kill. Now you're going to say, well, this is awful for lupus patients, but it's not relevant to me. And yes, it is. So now I want to tell you about the Swedish study. So this is a Swedish study in their general population, because you know most other countries have these wonderful databases that include absolutely everybody. And so in this study, they looked at just people who had taken 5 milligrams for 21 or more days. And they found the risk of dying went up 2-fold. And at the highest doses of prednisone, the risks of death included sepsis, which doesn't surprise you, but pulmonary emboli may surprise you. Please don't forget, prednisone is prothrombotic. So what is my goal? What is my treat to target in clinic? My patients who have seen me for many years sometimes start off the conversation by saying, Dr. Petri, I've been your patient since 1990. When are you going to put me in a remission? And I have to change the topic because we don't realistically use the word remission in lupus. Sometimes I tell my patients, lupus is the disease that keeps on giving. So I tell them my goal is to get their lupus under good control with allowable medications that they can tolerate. But we do have this treat to target that uses words like mild activity as being acceptable. So the physician global assessment, 1 or less, means mild. And sometimes I'm asking patients to accept things they don't want to accept, like having stiff joints in the morning. But can you see that this definition requires that the prednisone dose be 7.5 or less? So not perfect, but maybe this is something achievable. So we looked at this and found that if people could achieve this lupus low disease activity state for at least 50% of their visits, they'd have a 50% reduction in permanent later organ damage. Now, why did I phrase this as 50% of their visits? Because half of people with lupus have a flare pattern. They're fine, and then they wake up the next day with a lupus flare. Maybe it's rash, maybe it's joints, maybe it's pleurisy. And I can treat that and get them better. But on average, a lupus patient has about 1.5 flares per year. So even in that pattern, I know I'm not going to achieve 100% of visits with low activity. Now, what are our current treatment approaches? Since obviously I don't want it to be prednisone. So there's a lot of history in lupus, and the history of effective treatment of lupus actually began in World War II. So the soldiers and sailors who returned from the Pacific Front, they had been given anti-malarials while they were serving, and they came back home and they said to their doctors, if they had rheumatoid arthritis or lupus, I'd like to go back on this medicine. It really helped me. So this was a patient-driven story. And we've been using anti-malarials ever since, although we don't like to call them anti-malarials since they're no longer effective against malaria. The one we predominantly use is hydroxychloroquine. And I think it's so much fun that everybody knows how to pronounce hydroxychloroquine because of the pandemic. Before then, it was like, the patient would say hydro something. Now, why do we still use hydroxychloroquine? Because it actually prevents about half of lupus flares. But it also has a lot of other benefits. In patients with antiphospholipid antibodies, it can reduce thrombosis by 50%. It actually reduces cardiovascular risk factors. It can help to prevent diabetes. It reduces LDL cholesterol. Maybe I now convinced you that you'd like to take it. But the most important take-home message for our patients is that it is the one and only drug that we use that has improved survival in multiple studies. Now, this is important because patients sometimes think if they're feeling well that it's time to stop their hydroxychloroquine. And my job is to convince them they don't want to do that, because one of the major causes of death in people with lupus are things that hydroxychloroquine can prevent, like cardiovascular events and thrombotic events. It's non-immunosuppressive, so it does not lead to infections and it does not lead to malignancies. But it can lead to this. Does anybody know what test I'm showing you on this slide? So this is an OCT. It's basically an optical coherence tomogram. And what you're looking at the top is a snapshot of a normal retina, and you see that beautiful, nice dip in the middle. Down at the bottom is a photograph of hydroxychloroquine retinopathy. And the first thing you notice is that the dip is gone, and instead you see a structure there that looks like a flying saucer. So in fact, the ophthalmologists have nicknamed this the flying saucer sign. Now, back when I was a fellow, we were taught, and I think it was actually true, that only 1 out of 5,000 people on hydroxychloroquine ever got retinopathy. So we did not worry about it. Now, something has changed, and now it is more common. So we do have to think about it and talk to patients about it. And so in our longitudinal data, after people have been on this drug for 16 years, about 11% will have retinopathy and will have to stop it. The key message here is that as long as we do that OCT test every year, we would pick up retinopathy at such an early subclinical stage that when we stop the drug, there should be no progression and no loss of vision. So I still think this is the most important medicine we have. And in fact, I actually think it's good for the eyes because it will help to prevent lupus eye flares, which are called scleritis. It will help to prevent diabetes, which can cause visual loss. It will help to prevent a retinal clot from antiphospholipid antibodies. And in work that was just published last year from the University of Virginia, it helps to prevent maculopathy. So I always have to balance benefit and risk. That's what's called shared decision making. But I try to convince all of my patients to stay on this drug. Now, there's some other things I like, and some of them are quite controversial. I'm going to tell you a little bit about vitamin D. And first of all, it's not a vitamin. It's actually a steroid hormone that got misnamed. Lupus is the disease in which to study vitamin D deficiency and insufficiency because it's almost universal in lupus. And what we found was when we supplemented vitamin D, we saw improvement in proteinuria. Now, vitamin D has a lot of other potential benefits, and I know you've been told it's been oversold for the general population. I'm not going to comment on that. I only want to comment on women with lupus in whom we've been able to show reduction in cardiovascular risk factors. And in an oncology study, vitamin D supplementation actually reduced thrombosis. So I think we still have a lot to learn about vitamin D. But what about the immunosuppressive approaches? Because fewer than half of people with lupus can be managed on hydroxychloroquine alone. The rest are going to need immunosuppression. And we use a lot of different drugs that we have borrowed, either from oncology or, nephrology or rheumatoid arthritis. There are only 3 on this slide, which are FDA approved. So when you're in rheumatology, you do prior authorizations in your sleep and on weekends, and it goes on and on and on. And even when something is FDA approved, we still have to do prior authorizations. It's very complicated. We tend to pick the treatment for the organ. And so, for example, mycophenolate is our first-line therapy for renal lupus, but it wouldn't be for joints. It's not a very good joint drug. So methotrexate is our first line for joints. But sometimes I think I have effectively treated the lupus and I still have a very unhappy patient. And this was brought home to me, through a patient interaction where I said to the patient, "Your lupus is under good control." I thought I was giving good news. And the patient yelled at me and she said, "Dr. Petri." So, of course I turned to her. There's that temptation to be typing, but it's really important to look at the patient's face. And I said, "What's wrong?" And she said, "How dare you? I've been telling you for years how awful I feel. How dare you tell me that my lupus is under control?" And this is an example of a dichotomy that we faced in lupus that we've now actually got terminology for, so it can help to direct our conversation. So type 1 symptoms are the things that are from inflammation like rash, joints, nephritis. We have treatments for those. The type 2 symptoms are the ones that profoundly affect quality of life. They're not inflammatory, so our lupus treatments don't help. And these are things like chronic fatigue, chronic pain, anxiety, insomnia, brain fog. But it turns out that chronic fatigue is almost a universal complaint of lupus patients worldwide. And in fact, is the major cause of disability in people with lupus. So we're getting smarter about this. And it turns out the type 2 symptomatologies, you may know of that as fibromyalgia, share a genetic predisposition with lupus, which may explain why lupus patients are so liable to get a type 2 symptom. But also the type 2 symptoms have different omics, different mRNA signatures. So someday it should be possible to actually identify this early and hopefully through pharmaceutical research have much better therapies. But what about the biologics that we have or the new small molecules? One we've had for over 10 years is called belimumab, and it affects BAFF. Do you remember that BAFF is a protein that keeps B cells alive and has a special predilection to keep autoimmune B cells alive? And so it turns out people who are likely to have a good response to belimumab have evidence that B cells are driving their disease. And we know this because these are the patients that have low complement and anti-DNA. So belimumab was initially approved for non-renal lupus, but now has approval as well for lupus nephritis. And just a couple of years ago, we got a biologic that targets the interferon receptor. Now, you remember that over 50% of people with lupus have the interferon gene signature, but in particular, the interferon gene signature seems to drive cutaneous lupus. And in our clinical trials, we measure cutaneous lupus with this outcome called CLASI. And you can see in the phase 3 trial shown here that this biologic works really quickly. In fact, it really works within a month. And by 3 months, it's plateaued. It's really nice to know by 3 months if something's going to help a patient, so you're not asking them to take it for a long period of time if there's no chance of success. And we have recently published our experience that this works for all the different kinds of cutaneous lupus, acute, subacute, and chronic. But I don't always want to give immunosuppressive treatment. And that's why I like this trial, which was done in China. And please, we all need to get used to the fact that there's more clinical research being done in China than in the United States. So in this study, It was possible to reset the immune system. And how did they do that? A low dose of interleukin-2 increases T regulatory cells. People with lupus have too few Tregs, and the ones they do have don't work. And you can see actually within 12 weeks, there was really success. And by 24 weeks, there was great success, both in overall lupus, but also in lupus nephritis. Now, you have to be very careful. This has got one of those therapeutic windows. You can't give too much interleukin-2 because then you would increase effector cells that cause harm, like T cells and natural killer cells. So there are several companies in the United States that have tried to duplicate this. It hasn't gone really well, but I think in the future, we can't always immunosuppress for the rest of the person's life, because think what we cause. Not only do we increase infections, but we increase the risk of malignancy. Now, I want to really spend some time on lupus nephritis because it is probably our greatest unmet need. Did you know it's an independent risk factor for dying when you have lupus? And here's our problem. When we do the biopsy and we discover the person has it, they've already lost 1/3 of their nephrons. So every person with lupus nephritis is starting out with chronic kidney disease. Now, in this figure, you and I are that blue curve. We're going to lose some of our nephrons and podocytes as we get older, but we should be able to reach 100, and I hope all of us do, without needing dialysis. In a perfect world, it would be the middle red curve for a lupus patient. She will quickly go into a remission. She won't have a kidney flare. So she'll have 2/3 of her nephrons and then gradually lose some, but she won't be on dialysis until she's 90. But that's not the real world in lupus. The real world in lupus is the bottom red curve, where it takes us forever to get a renal response. And even when we do, the average lupus patient will have a renal flare and have another deep dive of loss of her nephrons. And so the nephrologist who taught me this, Professor Anders, is in Germany. And so he says in Germany, most of his lupus nephritis patients will be on dialysis by age 70. Well, that's Germany. In the United States, the lupus nephritis that we see is much more severe. And so I'm afraid that the majority of our lupus nephritis patients are headed for dialysis probably by 50. So what should our goal be? In our clinical trials of lupus kidney disease, the goal is to get the urine protein to below 500 milligrams. Is that normal? No, of course it isn't normal. This would be like if you had cancer and you go to meet with your first oncologist and the oncologist says, my goal after 1 year of treatment is to leave you with cancer. Wouldn't you get up and find someone else, get a second opinion? I think it's terrible that we've said it's okay to have just a partial response 1 year into treatment. So here's the evidence to back this up. This is a 10-year follow-up of a lupus nephritis clinical trial. And on the right, you can see that the people who had no response at 10 years, the majority are on dialysis. But look at the people in the middle. Those are the people that had one of those partial responses. And you can see the majority of them are on dialysis at 10 years. The only people who are almost guaranteed to be off of dialysis are on the left. Those are the patients who went into a renal remission. Their urine protein got back to normal. So we need to be more aggressive in our outcomes. So what are our new therapies going to add? Well, if we just gave mycophenolate at 1 year, probably only about 25% of patients would have reached the complete renal response of 500 milligrams. With belimumab, it's up to 43% at 2 years, but there's only an 11% delta over the standard of care, which was either mycophenolate or cyclophosphamide. The really good news with belimumab was in the appendix of the New England Journal of Medicine article. Has anyone here ever looked at the appendix? Ever? I'm not even sure I know how to do it. But in any case, this was the figure that was in the appendix. Look what happened by 20 weeks. Preservation of the GFR. And now think about it. Why are we treating lupus nephritis? We're treating it To prevent dialysis, of course, we want to protect the GFR. And some of you are saying, why isn't she telling us about SGLT2 inhibition? We have looked at that preliminarily in lupus, and it's not so hot, guys. It's hard to see GFR protection, and we see no reduction in proteinuria. So something that's a guarantee to protect GFR sounds pretty good, doesn't it? Now, here's the second new approved therapy. This is a calcineurin inhibitor. And yes, the generic calcineurin inhibitor tacrolimus has also been shown to help lupus nephritis. But this brand name, voclosporin, has very nice kinetics. So it's a fixed dose, 3 capsules twice a day. And this is a 1-year trial that showed an 18% delta in reaching a complete renal response. Now, there are some updates because it is a calcineurin inhibitor. Everybody wants to know, is there going to be any calcineurin inhibitor nephropathy? And the answer is in a small subset who got a kidney biopsy, that was not an issue. And GFR has been preserved up to 3 years. So at this point, no long-term worries. But our problem, again, remember, is that most of our patients will not even achieve a 500 milligram or less response by 1 year. And one of the issues is, how do we know that we're under-treating patients? We're following the urine protein, but you can have protein in your urine not just from histologic activity, but also from damage. So what we're working on is looking at the urine proteome. And my colleague, Andrea Fava, has found that there are multiple proteins in the urine that correlate much better with what's happening in the kidney than the urine protein. And you see those circled in blue, and you see how well they outperform the urine protein in red. So what we're working on is the equivalent of a urine dipstick. So every visit, a lupus nephritis patient could get checked for these proteins, and we could either escalate or reduce the therapy depending on how active the nephritis actually was in the kidneys. But now I want to get to the future. And you can tell I do read the New England Journal of Medicine. So this was one that shook up our community. First of all, we weren't expecting it. It wasn't as if it had snuck out, by word of mouth. This is an N of 1 case study published in the New England Journal of Medicine, which is best known, of course, for publishing major clinical trials that are going to change practice immediately. So why was the New England Journal of Medicine interested in an N of 1 study? Now, this came from the group headed by Georg Schett in Germany, and was the first published result on using CAR T directed against B cells in lupus. And the reason why it got so much attention was that the patient went into a treatment-free remission after receiving the CAR T. And she had multiple organs involved. You can see all of them in different colors, including lupus nephritis. We have never talked about treatment-free remission in lupus before. At best, and I'm on the committee that came up with the definition for remission, we talked about remission on treatment, or ROT for short, because we thought for sure people would still need their immunosuppression, their biologic, their hydroxychloroquine. We were not even thinking in this realm. Now, this was an N of 1, but he's followed that with an additional 7 patients, and all 8 now are in treatment-free remissions, although some only for 6 months. The longest experience is up to about 3 years. Now, this has shaken us up, but it's also shaken up the entire world, because there are now 18 different companies studying CAR T for lupus. Now, what are the problems going to be? Because you always have to look at the other side of the story. Cost. Does anybody know how much it will cost to do CAR T in a single person with lupus? $370,000. It's not quite as expensive as the complement inhibitor eculizumab, which used to be the most expensive therapy we talked about in lupus, but boy, it's getting there, isn't it? And now let's talk about the problems. So first of all, Georg Schett was treating middle-class, predominantly Caucasian lupus in Germany. We see much worse lupus in the United States, and our African Americans, our Hispanic Americans, even our East Asian patients. So we're going to have sicker patients. Is this going to work as well in sicker patients? The second is that CAR T is not easy. First of all, you have to taper the immune suppression and then do a plasmapheresis step to get the T cells. One of his patients had a major flare when the immunosuppression was tapered and had to be treated with cyclophosphamide. Secondly, once you get the T cells, you have to send them off so the CAR can be engineered. It takes a month then to get it back. We're probably going to want to do this for our very sickest patients, people in the ICU, for example, people with lupus nephritis that have the rapidly progressive types or rapidly going onto dialysis. They don't have a month to wait to get it back, do they? Then you have to precondition. Think of it as making room for these CAR T cells. And so you have to give cyclophosphamide and fludarabine. Really, a toxic immunosuppressive regimen. Then you give the CARs, and the idea here is you will achieve deep B cell depletion. But it's going to be maybe 3 months before the B cells come back. So there's a long period of time where that patient is going to be at risk of infections. And people with lupus get wild infections, fungemias, opportunistic infections, you name it. Now, the miracle that's happened is that in all the treated patients, when the B cells came back, they had reset. They didn't come back as lupus B cells. That's the miracle. And people want to know why. Why do they always reset in the right way? It may be that the target was CD19, or maybe it's some other part of the protocol. But bottom line is, don't mess with success. If this protocol works, my view is let's just copy it. But can you imagine also the time it takes for the patient to do this? While they're profoundly B cell depleted, of course, they're at great risk of infection. We'd rather not having them go to work during that period of time. But can you think of any employer who's going to give a lupus patient a 3-month pass? This just doesn't happen in the United States the way it happens in countries with socialized medicine. So I don't think we can offer this to all of our sick patients, but I would sure like to be able to offer it to many. Now I want to close with this slide because this is a beautiful painting by El Greco of Saint Sebastian. And it reminds me of what our lupus patients go through. And you're going to say, why did she show a man? Lupus is predominantly a female disease, but our men do much worse. Our men with lupus have a higher mortality rate. They're more likely to have end-stage kidney disease. They're more likely to have a myocardial infarction. But first of all, I want you to look at the face. Remember the suffering. A lot of the suffering is due to the type 2 symptomatology for which we don't have great treatments. But then look at all the arrows. So there are 2 arrows in the heart. Cardiovascular events are the second leading cause of death. There's an arrow in the arm, which is the hypertension arm. Lupus patients have almost universal hypertension, especially our lupus nephritis patients. I got to the point that when our medical assistant took the blood pressure, if I overheard it was above 120, I went out to give the patient the lecture. And the lecture goes like this. Did you take your antihypertensives today? You know how often your patient doesn't. So now we have a Petri rule. You must not leave home without taking your antihypertensive. And the excuses I've heard are very interesting. One excuse was, Dr. Petri, I was in a rush because I didn't want to be late for the appointment. I told them I'd rather have them be late and have their blood pressure be under control. Another excuse I heard was, it's on my list. Have you heard that one? But if it's on your list and you're not taking it, it gets a little bit ridiculous. Do we have to ask, have you swallowed it today? So as you start to talk about adherence with your patients, you're going to face all these issues. But there's a reason why hypertension is called the silent killer. It's hard to motivate our patients to take medications for things they can't feel. Now, I hope you see that one of the arrows is going into the lungs. 10% of people with lupus have interstitial lung disease, and we tend to pick it up late. Then you probably see some arrows in the kidneys. Remember, 70% of African Americans, by the way, 70% of East Asian patients with lupus have lupus nephritis. I feel like it's everywhere. So I check the urine protein to creatinine ratio at every visit. And now someone is thinking, boy, that's a waste of money. But is it? when early detection is everything? And maybe you think I should only check it in my young patients, but I check it in everybody. And I'll never forget one of my 80-year-old patients who was Caucasian. She'd been my patient for over 30 years. Her lupus had been as close to a remission as I'm ever going to see. And her urine protein came back over 500. I remember calling her and saying, this is probably nothing, let's repeat it. Can you guess the rest of the story? Yes, the repeat was high. We did a kidney biopsy. She had diffuse proliferative glomerulonephritis, or class 4, the worst kind. And luckily she is under good control with mycophenolate, but you can see I would have missed that if I wasn't checking all the time. So we think rheumatologists are the primary care doctors for people with lupus, but of course we need all of you. It always takes a village to take care of a complex patient. I want to thank you all for your attention this morning, and I'll be very happy to answer your questions.
Thank you, Dr. Petri, for an amazingly engaging and instructive grand rounds. I don't want to take it personally that you left out probably the most important system that's affected in autoimmune diseases, at least equal to the rheumatologic, the endocrine system. And the association of thyroid disease in lupus begs sort of the whole, so much we can learn from you in terms of the type 1 and type 2 symptoms, because oftentimes after correcting the underlying problem, we think, they still feel horrible, the type 2 symptoms. So oftentimes we can treat them with whatever medications we have, just as you do. But I'm sure there are patients that come to you and say, well, are there any other supplements, or is there a dietary treatment that you could recommend? Of course, I'm going to take my antihypertensive, but is there any other alternative therapies that you might recommend to your patients, and especially in light of the thyroid as well?
So thank you for bringing up autoimmune thyroid disease. But in general, I think our entire country is going to become much more interested in type 2 symptomatology because of long COVID, which is an example of that, isn't it? Or post-Lyme, there have been examples in rheumatology before. Now, our problem, of course, is when we're treating these type 2 symptomatology things, we're using medicines that we've borrowed from neurology. So in fact, I want all these patients to go to neurology, but neurology doesn't want them. And so we're the ones prescribing things like amitriptyline and gabapentin, and duloxetine is a favorite one we use in lupus patients, but they're not very helpful. They have benefit at the margin is the best way to describe it. So yes, my patients go out and surf the net trying to find the things that they're sure I've missed. And sometimes, you know, there's a little bit of a disconnect, because patients think that if there's a testimonial, that's as good as hard science. It's hard to explain to patients where we're coming from. But this can be dangerous in lupus, because one of the most common things patients read about and end up taking is turmeric. Did you know that turmeric in animal models of lupus has been proven to cause central nervous system lupus? So you can understand, you know, that's not a place I want a patient to go. And then the other thing is, many of our patients are interested in CBD, but in fact, in animal models, CBD accelerates lupus nephritis. And again, you know, don't put too much weight on an N of 1 study, but I have had patients who went overboard taking CBD and then ended up being hospitalized for a lupus nephritis flare. So I think probably those animal data do generalize. So in general, when something isn't tested, I say to a patient, we don't know enough about the benefits and the harm, and we certainly don't know what the effective dose is.
Thank you. There's a couple of questions on the chat that maybe we can get to, at least one of them. Dr. Culpepper Pace writes, how important do you think it is to follow the chloroquine blood levels in patients that you're treating with lupus on hydroxychloroquine?
So you remember that hydroxychloroquine has a lot of benefit, but it can also cause retinopathy in about 11% after 16 years. So the ophthalmologists, and in fact, even the American College of Rheumatology, came up with guidelines that said we should never, ever prescribe more than 5 milligrams per kilogram. I've been fighting that ever since because most patients on less than 5 milligrams per kilogram will not have a therapeutic dose. And why prescribe it at all if it can't help? So how do I know the patient's on the right amount? I do monitor the whole blood level. And this will remind you of a hemoglobin A1C. A whole blood level of hydroxychloroquine actually represents how much they took over the last month. And so you don't just figure out how much did they take yesterday or on the day of the visit when the person swallows it because they want to be adherent. And I have found this so helpful, and it's very easy. The whole blood goal is 1,000. And so if a patient has a very low level, I start to quiz them about adherence. If they're too high, then I reduce the dose. So I think therapeutic blood monitoring is really important, even though my own organization is against it.
Thank you, Dr. Petri. We have several other questions which we don't have time for. If we could, Frankie, keep a copy of the chat and we'll forward it to Dr. Chung and Dr. Petri for further comments. I want to thank everybody for attending in person and online. Please look at the chat in order to get the link